Good day. My name is Caolan Abrahams. I'm a senior house officer in anesthesia at Cork University Hospital, and I'll be presenting an audit on pre-operative fasting and fluid management in elderly patients undergoing hip fracture surgery at Cork University Hospital. Elderly patients present unplanned and often have a significant comorbid burden. Total hip replacement, regarded as major orthopedic surgery, in itself carries significant risk. The HSE has an integrated care pathway recommending fast-tracking surgery to occur within 48 hours of injury, as well as careful pre-operative planning and prehabilitation by a trained anesthetist. Whilst fasting is necessary for safe anesthesia, prolonged fasting carries additional risk, such as intraoperative hemodynamic instability, dehydration, and delirium. We aimed to audit and evaluate preoperative fluid management in patients undergoing emergency hip fracture surgeries over the age of 65 years. Over a 1 month period, we reviewed fluid balance charts as well as anesthetic records, recording the time that patients were kept no pass, the time of induction, the amount of fluids they received per kilogram of body weight where possible, how many patients were allowed to do sip till send, as well as the type of anesthetics these patients received. We came across 38 patients with an average age of 79. Of note, 2 patients had fluid charts missing from their files. 24 of these patients received regional anesthesia with sedation, and 14 received a general anesthetic for their procedure. The average fasting time for clear fluids was 8.6 hours, with the longest time recorded as 26.5 hours. The average fasting from solids was 13.1 hours, with the longest fasting time recorded as 31 hours, and 8 patients were allowed to do subtilsin. It is also noted that approximately 10 patients had no documentation reflecting the time of last clear fluid intake or IV fluids being administered during their no-pass period. Upon review, these gaps in documentation are unlikely to accurately reflect the level of care in the wards and are more likely akin to reflect errors in record keeping. Significant variation in data prevented further trends from being analyzed, and we were unable to fully assess adherence to the HSE integrated care pathway. This impacts continuity of care and adds a potentially avoidable layer of risk to planning surgery and safe anesthesia in an already high-risk demographic. We recommend exploration of electronic healthcare records and a degree of standardization to preoperative optimization where possible. A multidisciplinary education session aimed at doctors, nurses, and healthcare assistants, expanding on guidelines and the risks of prolonged fasting, as well as instituting of control measures to ensure more accurate and concise recording of fluid management in this high-risk group. Thank you for your time.